Hi everyone. My name is Kiat Ruxrungtham. I'm a professor of medicine Chulalongkorn University and also at the HIPNAT Thai Red Cross Research Center. So my pleasure to join this session. So what I'm going to cover in the next 20 minutes is a topic of HIV drug resistance in Asia, particularly including also include China, and how we're going to apply for our clinical practice. This is my disclosure. So the outlines of my talk, first I'm going to uh, give some background about what the principles of HIV drug resistance. So some of you that not familiar with uh, drug resistance will be get some basics backgrounds on it. And then I will move on to the prevalence of Asia's HIV liver transcriptase inhibitor drug resistance, including NRTI and NNRTI. And then we'll cover the prevalence of integrase strand transfer inhibitor resistance. We'll next we'll move on to talk about the future trend and how we're going to do at the clinical and public health implementation for controlling HIV/AIDS and also the drug resistant transmission issue. I think many of us are familiar with the epidemics of HIV. In this case, you have seen that in our regions, Asia and the Pacific, data from the UNS back in 2019. You can see that in our region, at least the estimation of people living with HIV uh, is up to 6 million people. The prevalence is in the adult is 0.2%. Um, is also a challenge in these regions that at least 300,000 people newly infected and also 160,000 people die from AIDS each year. And only 60% of them in average receiving antiretroviral treatment. Now, again, I believe most of the audience are familiar with the antiretroviral drugs available. Let me just highlight in brief that right now, the current major antiretroviral treatment options we can define into four classes of medicines. So the first one is the nucleoside liver transcriptase inhibitor, and this is the risk in, of this group. And the second group in integrase inhibitors, you have dolutegravir, rituximab, raltegravir, abiraterone need to be combined with the cobicistat. And the third group is the protease inhibitors. The two major protease inhibitors still using is the darunavir and atazanavir. Some countries still using ropinavir. And the last group is the non-nucleoside liver transcriptase inhibitors or NNRTI. So the currently used is mainly efavirenz, lepivarine, doravirine. Now, I think this is the principle of dropping drug resistance. I'd like to highlight here that we can group major factors that related to the risk of developing HIV drug resistance into three major factors. The first factor is whether that individual is infected with wild type or drug resistant or virus. So they infected with drug-sensitive virus, we call wild type, or infected with resistant virus. So the transmission of the resistant virus is the major one of the cause that may lead to drug resistance very quickly. Um, the second part is really uh, based on the characteristic of that selected antiretroviral therapy for that patient. So whether that ARV has high or low genetic drug resistant barrier, what that means is that how many mutation in that particular target uh, protein of HIV virus mutation that needed to become high level drug resistant. So if any drug that need only one single point mutation, we call the low genetic drug resistant barrier. If you need more than 3 or 4, that we call is a high genetic drug resistant barrier. It's also related to the potency of the drugs, and more importantly is the pharmacokinetic tail. It means whether the drug have the half-life is short or long. That's also one factor. I'm going to elaborate this a bit further. And the other major group of factor is either factor in the patients uh, uh, themselves or himself or herself, or the doctor who taking care of the patient, because the patient adherence to the treatment very critical, and the way that doctors selecting the regimen and the drug that for treating other diseases at the same time will create drug interaction or not. Now, let me um, cover a bit more the principle. If you remember that in the same class, some antiretroviral may have very easily to develop drug resistance because the high chance to develop drug resistance. In this case, it means 3TC and FTC in this group of the class of NRTI. TAF, tenofovir alafenamide, is the lower chance to develop drug resistance. It means high genetic resistant barrier. So if your regimen have 3TC, FTC, so you have a chance to develop drug resistance again, 3TC, FTC, if the patient didn't comply very well to the treatment. In the second class is the NNRTI. Nevirapine, efavirenz, rilpivirine is very easy to develop drug resistance compared to Duraviri. But none of the ARV in this class is really have high genetic resistant barrier. Interestingly, among integrase inhibitors, uh, the highest genetic resistant barrier or have the lowest chance to develop drug resistance is these two, is the dolutegravir and bictegravir. The chance to develop drug resistance is less than, it's only 0.1% compared to raltegravir in the same class is a 44 higher risk of drug resistant development. Now, remember that I mentioned beside the genetic resistant barrier, how easy to develop drug resistance is also the half-life of the medicine. We call the long pharmacokinetic tails. So if you select a regimen of, let's say, TDF, FTC plus any of the NNRTI, nevirapine, rilpivirine, efavirenz, you see that these two nucleoside backbone, TDF, FTC, they have like very similar. So within roughly about 24 hours plus, the drug level will be become suboptimum. But in contrast, the NRTI will take much longer times to become lower than the optimal level to control the virus. So in this case, if the patient missed the second dose for more than an hour, you can see that the patient will have a very high chance to expose to only one drug in the body. And this drug is very easy to develop drug resistance. That's why you do start to see NNRTI drug resistance in these individuals, and followed by, remember, the second one that easy to develop drug resistance is FTC or 3TC. In contrast to another regimen that you have, the pharmacokinetic tail is very similar half-life, and in this case, you see either you combine TDF-FTC with one integrase inhibitors or boosted PI. When the patient forgot to take the second pill in in the second day later than an hour, you still pretty safe because you didn't expose to only one drug in your body. So long tail PK need to be more careful in terms of adherence need seriously because it's less forgivingness. Now, let's move on to the prevalence of drug resistance. In this case, it's these two classes, because these two classes have been widely used in the world and also in these regions currently and previously. Let's look at the Asian data. There are quite a number of reports in the past a few years or decade. I select this review article back in 2013. This data is based on the data from 2005 to 2011. And you can see that among these study mainly is come from two countries. So it's not really well represent Asia as a whole regions. But at least it gives us some hint that if you look at the nucleoside or NRTI drug resistance in India, the prevalence in different report is quite high, is 8%. And in only a single Thai report is less than 5%. And when you look at NNRTI, interestingly, in India, it's also average is about 2%. In Thailand, it varies from below 1% to 3%. From PI, in India, it's vary from 1 to 3%. From Thailand, it's about 1 to 4%. So it really depends on the prevalence of drug exposure as well. Now, how about the report from China? So I select at least two publications. It's a very quite a large number of sample size. The first one based on the clinical sample from 2014 to 2015. This data is coming from Beijing, based on more than 900 patients. And you can see that they look at the subtype. So in China, it looks like the HIV subtype is quite a mix. More than 50% is the subtype that widely spreading in Southeast Asia. So this is the AE. In Thailand, it's more than 90% of HIV infected people carrying this strain of AE. So in China, it's more than a half, and another 20%, 21% is B and BC, recombinant BC. How about the transmission of drug resistance? The overall drug resistant transmission in Beijing data is 6%, so it's very close to the Indian data. 3% resist to NNRTI, 2% is resistant to protease inhibitor, and 1.3% resistant to NRTI. The other report from Shanghai, this is more recent data, back in 2017. The population sample size is about 300 patients. Again, AE subtypes, recombinant AE subtype is also very common. The second common in Shanghai is 30% is BC recombinant strain. Interestingly, Shanghai has a much higher uh, transmitted drug resistant or primary drug resistant uh, in the population, infected population. Remember that in Beijing is 6% overall, and this is 17%. So it's more than twofold higher, and 16% compared to 3% in Beijing. This is 16% in Shanghai resistant to NNRTI, 5% resist to protease inhibitor. Now, I bring more information from the WHO report in 2019. Basically, this is the survey report from 44 countries globally, valid from 2004 to 2018. The reason that we need this type of survey data, because this will guide the country whether they, in the guideline, they should do HIV drug resistance screening test. Basically, this is the guidelines from the WHO. Any country that have the prevalence lower than or no more than 5%, you don't need to do resistant testing screening. But if you have resistant prevalence, pre-treated resistant prevalence more than 10%, you should consider to recommend for drug resistant screening tests before starting ARV. Now, this is also part of the WHO report on drug resistance survey among 44 countries. But I just highlight here in the box here, you can see that among these 4 countries not well represent the whole regions, but at least you see that in Southeast Asia, just a second, let me try to, Myanmar and Vietnam, the prevalence of drug resistance is lower than in Nepal and Papua New Guinea. So in these 2 Southeast Asian countries, it is not required to do resistant screening, in contrast to Nepal, ideally, and Papua New Guinea. So it's higher than 10%. So ideally, they need to do a baseline drug resistance screening. The other way to look at the data is what type of drug resistance transmitted among these survey in that particular countries. You see that in general, as I mentioned at the beginning of my talk, that NNRTI is the most easy group to develop drug resistance. So it's no wonder that you're going to see any country, if you have the high prevalence of transmitted drug resistance, the majority will resist to either nevirapine or efavirenz. Okay, and the second group will be cytidine analog, either FTC or 3TC. How about the resistant prevalence within integrase inhibitor in Asia? So that's why most of the guidelines, including the US, WHO, and the European guideline, and you can see that dolutegravir, bictegravir, this is I highlight here in bold is the integrase inhibitor-based regimen as less common as a first line, more common than NNRTI. So NNRTI will need to be transitioned. So, but currently and in the past, particularly in this region and in African country in particular, so people have been using NNRTI a lot, particularly efavirenz-based triple regimen. So it's a time to transit from efavirenz to prescribe more integrase inhibitor, in this case dolutegravir. It could achieve regimen. So either start with the patient naive people or switch from currently back treatment regimen in NRTI base into dolutegravir base or as a second line option, because this we believe that will be lead to a lower prevalence of drug resistance compared to NNRTI based regimen. Uh, and this has been evident. I think we're going to hear more from one of the speaker from Taiwan. So I use this slide from one of the very known expert from Taiwan, Dr. Chen Ching Hang. So, and you can see that in this region, the prevalence of transmitted integrase inhibitor in this region is very, very low. Remember that compared to NNRTI in China, you have seen 17%, but in NNRTI and other, but integrase is very low. In China, it's at 0%. In many countries, lower than 1%. And he have shown that if you select, so in Taiwan have switched from NNRTI base in blue column here. So, from 90% back in 2014 and replaced by integrase inhibitors. You see that right now, until 2018 and 2019, so 1 or 2 years ago, you see that majority of patients in Taiwan treated with integrase inhibitor compared to only 5% with NNRTI. So what happening in terms of efficacy? So efficacy is very high if you look at viral load under 50 or 20 copies. So it's more than 97, 98%, almost 100% viral suppression. And that lead to, you remember that the integrase inhibitor have been using more, and we start to see the drop of NRTI drug resistant transmission in Taiwan, and also nucleoside resistant transmission in Taiwan also dropping. So let me summarize my talk here that it's very clear that these two class or these two, NNRTI class and cytidine analog, either 3TC or FTC, has a very low genetic resistance barrier. It's been very easy to drop drug resistance, only 1 point mutation. So it's very easy to see a rapid dropping of drug resistance in patients with poor compliance. And that also result to a high incidence of transmitted viral resistance to this group of ARV. And overall pre-treatment drug resistant prevalence in recent surveys show that it's much higher than 10% in several countries, in African countries, continents, and in Latin America compared to our regions. However, among our regions, some countries like the India, Nepal, Papua New Guinea, or some region in a province in China, like Shanghai, has more than 10% prevalence of NNRTI drug resistance. So in terms of transition from NRTI-based regimen in different countries to DTG-based regimen as a first-line option, we believe this is a strategy that very important to avoid the need of baseline drug resistance screening, and it's likely that to help us to reduce the future prevalence of drug resistance in that particular country or region as well. But I think it's very important that our goal is to really aim to end HIV/AIDS in the world, so in our country. So if we want to do so, more effort is required to implement widely of PrEPs, pre-exposure prophylaxis, same-day rapid ART, and gearing toward DTG-based ART regimen. So I'd like to thank you very much for your kind attention. Thank you.